Predicting psychosis, the long game. So here's what nobody tells you. Most people who show early warning signs of psychosis never actually develop psychosis. They just struggle. They get hospitalized, they lose jobs, they cycle through mental health systems for years. And we've basically been ignoring that part of the story because we're so obsessed with the transition itself. What if the thing we should actually be predicting isn't whether someone gets sick, but whether they're going to keep suffering? That's exactly what researchers at King's College London decided to find out. And what they discovered is uncomfortable enough that it might change how psychiatry thinks about early intervention. Here's the thing about clinical high risk for psychosis. Psychiatry has spent the last couple decades getting really good at spotting the people who might be on their way to a psychotic episode. We've got frameworks, we've got warning signs, we've got statistical models. But almost all of that research happens in carefully controlled studies with populations that barely resemble the messy reality of actual mental health clinics. In the real world, if you show up at a hospital with some early psychotic symptoms, nobody knows what your life is actually going to look like in 5 years. Will you transition to full psychosis? Maybe not. Will you still be struggling? Almost certainly. But that's not what we've been measuring. We've been so focused on the dramatic binary outcome, psychosis or no psychosis, that we've completely missed the nuanced, complicated middle ground where most people actually live. This study was designed to change that. It's called OASIS 1000, and it's the kind of research that takes years of unglamorous work to pull off. The lead researcher here is Yajing Logeswaran, based at the Early Psychosis Interventions and Clinical Detection Lab at King's College London. She's part of a larger team that includes Paolo Fusar-Poli, who's kind of the big name in early psychosis research, along with clinicians and biostatisticians scattered across London, Oxford, Naples and Munich. The study was published in June 2026 in World Psychiatry, which is essentially the premier journal if you care about how mental illness actually manifests across the planet. What they did was follow over 1,000 people who walked into real-world mental health clinics in London. Not research volunteers, not carefully selected participants, just people who showed up because they were experiencing some early warning signs of psychosis. They tracked them for years, looking not just at whether they transitioned to psychosis, but at every bad outcome that actually mattered. Hospitalizations, substance abuse, dropout from care, functional decline, you name it. Think of it like this. We've been treating the early warning signs of psychosis like a fire alarm that either goes off loudly or stays silent. But this research asked a different question. What if most of the time the alarm doesn't go off loudly, but the building is still burning? What if the damage happens whether or not the alarm reaches the threshold we care about? The methodology was prospective, which means they followed people forward in time rather than looking backward at records. That's harder and more expensive, but it's the only way to actually predict outcomes. And they used real clinical data, the kind of messy, complicated information that actually exists in mental health settings. Not lab-clean assessments, not perfectly administered questionnaires, just what clinicians actually documented when these people came in for help. The team looked at a whole range of baseline characteristics, what symptoms people had when they arrived, how severe those symptoms were, whether they had substance abuse issues, what their functioning looked like, whether they'd had previous psychiatric episodes, all of it. Then they followed them and asked a simple question. Which of these people ended up with poor long-term outcomes? Here's what they found, and this is where it gets interesting. Most people in this group, and I mean most, didn't transition to psychosis. If you're keeping score at home, that's actually good news. But, and this is a huge but, most people also didn't do great. A significant chunk experienced hospitalization. Many dropped out of treatment. Some continued to deteriorate across multiple areas of life, even without hitting that psychosis threshold. So the traditional model of risk stratification, which basically divides people into will get psychosis and won't get psychosis, is almost useless for predicting actual suffering. When the researchers looked at which factors predicted these poor long-term outcomes, they found something unexpected. The things that predicted transitioning to psychosis weren't the same things that predicted long-term suffering. It's like discovering that the indicators of a dramatic crisis are different from the indicators of chronic struggle. Substance abuse was a massive predictor. People who were using drugs when they came in had significantly worse long-term outcomes, even if they never developed psychosis. Baseline functioning mattered too. If you came in already struggling to hold a job or maintain relationships, you were likely to keep struggling. Previous psychiatric episodes were a red flag, but some of the traditional early psychosis predictors didn't matter nearly as much as we thought. The effect sizes here are real. We're not talking about subtle statistical differences. We're talking about doubling or tripling the risk of poor outcomes depending on which combination of factors someone had. So what does this actually mean? First, it means we need to stop thinking about clinical high risk for psychosis as a single category. There's not one group of people we're trying to predict. There are multiple groups with different trajectories and different needs. Someone who comes in with substance abuse and poor functioning but no psychotic symptoms is not a lucky version of someone who develops psychosis. They're a different problem entirely, and they need a different approach. Second, it suggests that our whole intervention framework might be slightly misdirected. If most people in this group won't transition to psychosis, why are we organizing everything around preventing that transition? Maybe we should be organizing around preventing hospitalization, maintaining employment, keeping people engaged with treatment. That sounds obvious when you say it out loud, but it's not how most mental health systems are set up. Third, it raises a genuinely uncomfortable question. Are we over-pathologizing early psychotic experiences? If someone has attenuated psychotic symptoms but good functioning and no substance abuse and strong social support, should we be putting them through the same intervention protocols as someone who's falling apart? The research suggests maybe not, but that's a decision with real ethical implications. The limitation worth naming is that this is observational research. We're seeing associations, not causality. We don't know if substance abuse causes poor outcomes, or if poor outcomes drive substance abuse, or if both are symptoms of some deeper vulnerability we're not measuring. The researchers were careful about this, but it's worth keeping in mind. This research also opens up questions about where this fits in the broader landscape of psychiatric prediction. We're increasingly able to predict bad outcomes, but we're much worse at preventing them once we've made the prediction. Knowing that someone is at risk of hospitalization doesn't automatically tell us how to keep them out of the hospital. So there's a gap between what the research can tell us and what we can actually do with that information. What should come next is intervention research. If we can identify who's at risk of poor long-term outcomes, can we design treatments specifically for those people? Can we do something different for someone with substance abuse and early psychotic symptoms than we do for someone with attenuated psychosis and good functioning? That's the question that actually matters. This research matters because it reframes what we should actually be trying to prevent. For decades, early psychosis research has been structured around the most dramatic outcome. But dramatic doesn't mean important. For the 1,000 people in this study, chronic dysfunction probably affected their quality of life more than the theoretical risk of psychosis ever would have. And that's what medicine is supposed to be about, making people's lives better. Turns out, scientists have been busy, and they're not done yet.